So tumor sidedness is it's an evolving topic. The simple answer would be right-sided patients do worse than left-sided patients, or patients with primaries on the right versus left. And in the big picture, it looks like the EGFR antibodies are not effective on patients with right-sided cancer. Now, it's obviously not right versus left side. There's some biological surrogate here, and we're trying to figure that out, because I don't think it's true that every patient with right-sided cancer would not benefit from an EGFR antibody, or that every patient with left-sided cancer does better with an EGFR. But right now, we've been unable to subset that. So the way we use that as a decision maker is we do not use EGFR antibodies as first-line therapy in patients with right-sided disease. Patients with left-sided disease, we use the EGFR antibodies or Bev. Now, how do we make that decision? To me, the right-sided patients where the survival is 13 months, at least in our study and in 2 other contemporary studies, it's 13 months with EGFR, and in the 25 to 30 month with Bev on the right, clearly you don't want to use an EGFR agent because those patients do poorly. On the left, where the survival is more like 30 versus 33, where the patients do much better, I think it's much more important to think about the quality of life in those patients where it doesn't make such a big difference in survival. So yes, it's true, we don't recommend specifically EGFR on the left, and we recommend against it on the right, but I think that's sort of the way we make the nuanced decisions. Ultimately, for subsequent therapy, I don't think the data tells us one way or the other about EGFR. There's a little bit of data that says it's not a very effective agent anytime for right-sided patients, but I don't think it's definitive.